Hi, I'm Alison Martin, and I'm currently enrolled in the Jefferson College of Health Sciences MSN program with the Nursing Administration track. I've been a nurse for 10 years. I graduated from the University of Virginia in 2001. I worked at the emergency department at Roanoke Memorial ever since I graduated. I was a clinical team leader for 4 years and have been a unit director in the ED since 2011. Just a little bit of background information about the emergency department for those of you who may not know much about it. It is physically a very large place in size. We currently have 72 patient beds. We employ about 220 people in the emergency department. This includes nurses, EMTs, secretaries, clinical administrators, and MedCom staff. We currently have an average daily census of about 225 to 250 patients per day, and this equals out to 85,000 to 90,000 patients per year. Clearly, the emergency department is a very big, busy, chaotic place to work, and one of the most significant risks for patient safety can be medication errors. This is something that we have worked hard to try to combat and also have looked really closely at our processes for. We noticed about 2 years ago a pretty significant or alarming rise in medication errors, especially in regards to high-risk medications. Some of these that we would include or think of in that category would be things like insulin, epinephrine, TPA, or Angiomax. Following our process of just culture, we wanted to provide an environment where it is non-punitive and really supports staff to report errors and near misses so that we can look at what was the whole reason that brought us to why that occurred. We also wanted to take a step back and look at processes that we had in place which might easily put employees in a place where they might make errors and see what changes we could make to this. Through this, we were able to implement barcode scanning of all medications. This certainly creates a much safer environment for our patients and our staff really as well. The problem is that employees still have to use the process, and they also still have to have the critical thinking skills to know when a wrong order has been placed by a physician. Recently, I've had to deal with an employee that gave epinephrine wrong and had a medication error. It was given via the wrong route. And then as recently as last night, I had to deal with an issue regarding a resident who had placed an order wrong, again for epinephrine in regards to an allergic reaction. In addition to the order being placed wrong, it was placed for the wrong dose and the wrong route. It was also then subsequently verified by the pharmacy. Luckily, the mistake was caught by the nursing staff, and it was a near miss and did not actually reach the patient. But these are just two examples that I can think of that are even fairly recent that can show even with pretty significant safety standards and safety nets in place for people that significant mistakes and errors can still occur. Medication errors is something that I would certainly like to learn more about. Working in such a big and busy place, we deal with a lot of different quality issues. Some of them might be falls, pain assessments, and inpatient boarding, just to name a few. I'm certainly looking forward to learning more about quality and safety resources and methods to address issues such as these so that we can work to improve quality of care and experiences for the patients in the emergency department.